Hey everyone, welcome to another edition of The Right Way Wednesday. My name is Nicole Clark, a part of the Health Pro Heritage QA and Compliance team, and today I have with me Diane Palacio, who is visiting. And we've been working away all day long. You see, we're still working even into the evening. And one of the things that we've talked a little bit about today as a team is the audit environment. Under our old RUG score system, we were used to audits. We knew that audits would continue under PDPM. We knew they were coming, and now we're actually starting to see them happen just a little bit, not a lot, but they are kind of starting in some areas. And so we're beginning to see those kinds of ADRs. And if you don't know what an ADR is, that's an additional documentation review. That's when a payer asks to see our documentation to determine whether or not they either paid us appropriately or they need to pay us for what we've done. And so I know we've just started seeing them. One of the most common questions we've been getting from our customers and from our teams are, how are these audits under PDPM going to be different than before October 1st?
So it is kind of the $1,000,000 question, because none of us have a crystal ball, so we're guessing until we actually see and have some data behind us. But I expect that they're not going to be that different. Ultimately, all of these audits are looking at whether the documentation supports reimbursement, right? Whether our documentation supports our billing. So that's not any different under PDPM than it has been under RUGs or even for Part B CPT code billing. They still want to know that our documentation supports what they're paying for. So that said, I don't think they're going to be that significantly different, but we do know that there's certain patient characteristics that have become much more important under PDPM, and of course they're going to be looking for the documentation to support those. So, swallowing difficulties, dementia, depression, all of those things suddenly carry a little bit more weight than I think they did in the past. So documentation is obviously going to have to support those if we're coding them. So I think they're going to ultimately be looking at the MDS first and foremost, and then of course the backup documentation to the MDS. So therapy, dietary, whatever other departments are able to support what is coded on the MDS. So,
right.
Yeah.
Yeah. So, we know, and by the way, my dog Lucy has arrived and says hi. She apparently wants to be in the video quite desperately right now.
Nobody's paying any attention to me right now.
So say hi to Lucy. So we know that the relationship between therapy documentation and nursing documentation has always been really important, right? But because of the way now under PDPM the MDS is structured, and I mean that by way of what items now impact payment that didn't before, and what items no longer impact payment that did before, we know that relationship is even more important than ever. So thinking about that, are there things, do we need to send different items, or do we need to send different things now for our ADRs than we did before, or the same?
Do we need to send different items? No. Do I think we need to send much improved documentation? Yes. And by what I mean by that is, I think therapy is kind of used to being under the gun. They're used to audits. We've been having therapy audits or audits that focus on therapy documentation for years. Right. It's not new to us. I think nursing is not used to it. While obviously they had to submit MDSs in the past, their detailed day-to-day documentation and support of coding was not necessarily what was scrutinized because it didn't affect reimbursement.
Right.
So do I think that that is going to be something that's a little bit different, a little bit of adjustment? Yes, I do. But overall, we're still going to send the same information. The MDS is what's coded. The MDS is what ultimately results in the reimbursement. And so all the documentation that backs up that MDS is going to be under greater scrutiny than it was before. So yes, we're going to have to document depression and all of the incidences of it, the mechanical diets, the dysphagia or swallowing problems. Yes, that is going to have to be, I think, a lot more thoroughly documented than it was in the past. But as far as what records do we send, we're still going to send the MDS, we're still going to send the care plans, we're still going to send the hospital records, we're still going to send therapy, dietary, social services, everything that contributed to the care of that patient, which is what ultimately has to be supported
Right.
in the billing.
And like we always say, the documentation, ultimately the documentation requirements, those basic requirements have not changed with PDPM. They remained the same. They're just going to be looking at it more closely.
Well, and the skilled level
Right.
of care requirements haven't changed under
Right.
PDPM.
That's right.
Exactly. It's the exact same reason
Right.
before October last year as to now are the qualifying criteria
Right.
for Part A stay, and so that hasn't changed. What's changed is how we support it in our documentation.
So let's talk about the different types of audits, because there are a lot of different types of audits out there. I think some people hear TPE and RAC and CERT and get really nervous and kind of confused about what that means. So does what we send change depending on the type of audit it is?
No, because ultimately all of the audits are more or less looking at the same thing. They all want to ultimately know, does our documentation support our billing?
Right.
Some of them have more of a data focus. Some of them are looking more national trending. When you think of what a CERT audit looks at versus an SMRC audit versus a UPIC or a ZPIC audit, they are looking at the same information differently. But ultimately, they still need the same information in order to analyze and come to their conclusions. So, no, what we send for each audit is not necessarily going to vary. Remember, the ultimate, driver of what is included in an ADR packet is always going to be the documentation that supports the billing.
Right. So, Diane, thinking about our clinicians out there who are just fighting the good fight, treating our patients and just trying to do what's best for them, and even the rehab directors out there who are involved in that ADR and denial process directly once it starts happening. What's your best piece of advice that you can give to each of those groups when thinking about audits and making sure documentation is where it needs to be?
I have such respect for their position. It's a difficult position. You are pulled in 27 different directions at any given day.
Yeah.
A lot of moving parts to what you do. I think probably the best advice I could give you in terms of ADRs and denials, how you manage them and how you prepare for them, would be organization. Have a system for how you process them. Be consistent with how you process any kind of ADRs or record requests. Be collaborative. Be part of the team. You don't have to handle it all by yourself,
That's
particularly with Part A audits. It's collaboration. Therapy is no longer the primary driver of reimbursement, so all of the departments need to contribute to compiling that packet that supports the services that were billed. So be part of a team, form a collaborative team, form an ADR response team in your facility so that everybody has their role to play when ADRs come down the pipe. Be organized, be prepared, have a system, know what you need to do before you get an ADR. We have a lot of resources in Box, in the ADR denials resources folder that will walk you through what needs to go in the packet, recommended orders, putting dividers in the packet so that it's easy to navigate through that packet, to the different types of ADRs, the different types of audits. We have a lot of resources at your disposal, so use them, become familiar with them, so that when you get an ADR, you're not going, what must I do now? You actually have a plan in place. And of course, make sure you communicate with your QAC lead, your clinical services team, and your RVPs so that they're in the loop when you have audits, so that, we have to support each other.
Right. And if you're not a Health Pro Heritage clinician, make sure that you know who that team is, that supportive team is for you, so that when it happens, you're ready. Yeah.
Yep.
Good points. Thank you.
Thank you.
So another great conversation with Diane here. Let us know if you have any questions or comments below in the chat box. Thanks so much for joining us, and happy documenting. Bye.
Yep.